Rapid start initiation. What does that mean? Well, on Plus Talk today, I've got Dr. David Malebranche here, who's going to break it all down for us. Good to see you, Doc.
It's good to be here, Karl. As usual, I always enjoy talking to you.
Likewise. Now, I should point out, David, that you are a prominent, well-respected researcher and clinician working in HIV, and you have been for decades. You're also the Senior Director for Global Medical Affairs at Gilead. And I just want to point out before we start that any of the views or opinions that you express today on this episode of Plus Talk, they are your own. They don't necessarily reflect the views or positions of any entities you represent.
Absolutely.
Now that we've got that out of the way, rapid start initiation. I hear this, I see it in print. What does it mean?
Yeah, it has a whole bunch of different meanings, to be honest, but what it's morphed into is really focusing on starting someone who's newly diagnosed with HIV within 7 days of them finding out that diagnosis, or optimally on the same day. I think there used to be stretches where they'd say rapid start could be 14 days, 30 days, something really focused, but now it's really morphing into a timeline of either the same day or at the latest 7 days after diagnosis.
And why is that so important?
It's important for a number of reasons. From an individual level standpoint, obviously, when someone is newly diagnosed with HIV, especially in the setting of acute HIV, when the viral load may be very high, starting someone as soon as possible gets that viral load down. It decreases the replication of the virus, helps your immune system to be stronger and not be so decimated at the beginning of HIV acquisition. And then individually, someone will be a lot better from a physical standpoint immediately. From the other standpoint, where we're looking at a public health consideration, we do know that a lot of HIV transmission happens. People contract HIV when they are exposed to someone who's not on treatment. So if you're emphasizing rapid start, getting someone who newly diagnosed, getting them on medications quickly so that their viral load goes to undetectable, then you have undetectable equals untransmittable. So the sooner you get people to undetectable equals untransmittable, or U equals U, the better of a public health benefit it will be. The one last thing I will mention about rapid start that I think people don't talk about enough is how it impacts stigma. And I think there is literature, we have literature about it. One of our colleagues, Ofale Mbako, who is based in New York City, he actually did a study looking at rapid start and looking at the impact on stigma, and found that a lot of people who newly are diagnosed with HIV will think to themselves, oh my God, do I look like I have HIV? Will people be able to tell what's going on? So I think if we look at it from a physiological standpoint for the individual, yes, there's benefit. From a public health standpoint, to whether someone can transmit it to their sexual partners, there's a benefit there. But then I think in addition, we're starting to realize starting somebody rapidly on HIV treatment within a day or within a week really helps to ease some of the anxiety, helps to ease some of the internalized stigma that people will experience with the diagnosis.
Yeah, I would think that it's sort of like, okay, I'm taking control, I'm getting on top of this. And that in and of itself, I think, is sort of a positive reinforcement for somebody who's just been given, what shouldn't be horrible news anymore, but still is. Can anyone who receives an HIV positive diagnosis reach undetectable status?
Yeah, everyone has the potential to. The medications are so good right now that it's not in the past where you had to take multiple pills multiple times a day, large number of side effects and drug-drug interactions. Most of the regimens that we have available right now are very, very easy to take, very safe, very tolerable. And so people can take them with ease, whether it be one pill a day or injectable, long acting. You can do all these different modes of therapies right now that are available at your disposal, and people can get to undetectable. Recently is within like 1 month. You see people getting undetectable within 2 weeks to 1 month. Sometimes I've seen in my clinical practice.
So, question on that: why is it that some people become undetectable quicker than others?
Yeah, there's a host of factors. So everyone's body is going to be different, obviously. So it depends on the timing when you actually acquired HIV, how long of a time the viral load has been allowed to replicate. And so if someone comes in with a viral load, I've seen viral loads as high as in the 10 million region, whereas undetectable is physiologically defined as less than 200. that viral load can get up in the millions. So some people who may be up in that 5, 10 million region will have maybe a longer time to get to undetectable. It may also do with the age of the individual, other comorbidities they may have, high blood pressure, diabetes, asthma, all these kind of other conditions that people may have that may impact the immune system and how the medications work. And then how adherent someone is at the beginning. So are they taking the medications effectively? Are they taking it as prescribed? All these factors can come into play in getting somebody undetectable. And so some people may be able to get to undetectable within 2 weeks to a month. Others it may take weeks to months. I think the important message that I would give people who are with HIV out there is not to compare yourself to other people. So if you know that you had a friend that's like, oh my God, I had a friend who got to undetectable within a month. It's been 2 months. Why am I not undetectable? If you're going down the right course, stick with your clinician, stick with your healthcare provider, and have that conversation to make sure. I think a lot of us may panic sometimes in thinking that, oh my God, is the medication not working? What am I doing wrong? We internalize it. And I want to encourage people to get away from that way of thinking. Just realize that people's bodies are different and the way we process medications are different and are subject to a variety of host factors.
So what happens then, if the treatment that I'm put on just doesn't seem to be working, doesn't seem to be getting me to undetectable? Am I screwed? Is that it? Am I going to get full-blown AIDS and die?
Yeah, no, that's not the case. If we looked at that like 20, 30 years ago, people would probably panic and go to that way of thinking immediately. But I think nowadays, what I encourage people to do is really focus on communicating with your provider, communicate with your clinician, speak to them and say, hey, what's going on with my viral load? Do I need to be concerned? What's happening? What other options do I have available? Clinicians can get what's called a viral load test and a genotype or resistance test to check to make sure that the virus that you have is not resistant to any of the medications that you're currently on. But that's a little bit down the road, and that's if the viral load gets to a certain level. And so you want to make sure that you're actively communicating, staying on top of your labs, knowing what undetectable means. And for a lot of people, for a lot of the research studies, it means less than 200 copies of the virus in your bloodstream that can be detected. But then the science has it where the lab tests that we have now can detect less than 20. What I see sometimes with people is that between the levels of a viral load of 20 and 200, if you're like in the 100 range, people are like, oh my God, I'm not undetectable. You are still undetectable. According to the literature and the scientific studies, you're less than 200, so you can't pass it on. I think when your level gets above 1,000, when it's reaching the thousands again, that's where you need to say, well, hey, do we need to do some additional resistance testing to make sure I'm on the right medications right now?
Yeah, that sort of leads me to my last question. What happens if I become detectable after having been undetectable for a while?
Yeah, I think you have to look into a number of factors. One, the first thing you ask yourself is, well, am I taking the medication as it's supposed to be prescribed, as often as it's supposed to be prescribed? You look at other medications, there may be interactions with either vitamins or different medications for different medical conditions, like we talked about earlier, that could be interfering with how effective or how well your medication is being absorbed into your body. And I think also just really not beating yourself up. There is a term that we use in the scientific community that's called blips. So we call it a viral load blip. So
I've had blips over the course of my 17 years.
I've had blips in the course of my 17 years too. So it's one of those things where if you're under 20 all the time or under 50 all the time, whatever the cutoff is at the clinic where you attend, if you bump up to say 100, 160, could it be the time of day that you got it? Could it be that you missed a dose in another area? Could it be something with your immune system that you're not sure what's going on, that you may have been under some stress or something else may have happened, and all of a sudden it got you to this point? You don't know all the time. So I would tell people not to panic when you have those blips, which are usually described as a viral load between 20 and 200, and just follow up with your clinician. Actually, interesting story. I had a friend of mine call me, this was probably about 2 months ago, and panicked because they were usually under 20 and their viral load got into the 70, 80 copies range. And they said, oh my God, my clinician said I had to come in and I had to do all this stuff. And the clinician was actually panicking over that little blip. And I explained to him, I said, look, there's a blip. Have you noticed anything different with your diet? Have you started any other medications? Are you on any vitamins that you want to talk about? And we really had a good conversation about that. But he was so anxious about it because he immediately knee-jerked to, well, oh my God, my medications are failing. I'm going to die, or this is not going to work, or I won't have any options moving forward. And when he went to follow up with the doctor, all they did was repeat the viral load, and he was back under 20 again. So again, it's kind of one of those things where your communication, but it's that internal voice that often says, oh my God, what did I do wrong? This is going to be the end of the world. Something bad is happening. The medication's not working. Try to stay out of that negative framework of thinking and say to yourself, well, okay, this could just be a normal variety of life. And even when we're not getting our blood tested, there's probably little blips here and there that we aren't even aware of. So just assure yourself that overall, if you feel good, if you look good, if you're running around doing everything you want to do and don't have any problems, don't get too panicked about those little blips. Follow up with your clinician, repeat the viral load, and then see where it goes from there.
Dr. David Malebranche, you always put it in plain talk and you do it so reassuringly and comfortingly. Thank you for having this chat about rapid start initiation and blips and everything else. I really appreciate it.
I appreciate it. Thanks, Karl.
That's going to do it for this episode of Plus Talk. If you want more information about what we talked about, check out the website, pluslifemedia.com. And remember, we are on all of your favorite social platforms at Plus Life Media. Until next time, be nice to one another. If you haven't had an HIV test in a while, go get one. See ya.